Welcome to UD Talks, the podcast brought to you by United Drug, Ireland's leading pharmaceutical wholesaler and distributor. Along with our host, Denis O'Driscoll, we're here to bring you the latest insights, trends and innovations in retail pharmacy. Each episode, we'll dive into a range of topics that matter to you, from cutting-edge pharmaceutical developments to the day-to-day challenges faced by retail pharmacies. We'll be joined by industry experts to share insights and explore the future of pharmacy in Ireland. UD Talks is your go-to source for staying informed and inspired.
The content of this podcast is intended for pharmacists, healthcare professionals, and individuals with a professional interest in community pharmacy. While every effort has been made to ensure the accuracy of the content within this podcast, United Drug cannot accept responsibility for any mistakes, errors, or inaccuracies. Listeners are strongly advised to verify the information contained in this podcast with a relevant healthcare provider or seek medical advice where appropriate before acting on any information provided. United Drug shall not be liable for any loss or damage arising from the use of the information contained in this podcast. This disclaimer operates to limit United Drug's liability under contract, tort, including negligence, or statute. This disclaimer is provided to ensure that listeners are aware of the limitations of liability before they rely on the content. By continuing to listen to this podcast, listeners signify their assent to this disclaimer.
Hi everyone, and we're here for a podcast today with Jo Bergin. Jo is a candidate Advanced Nurse Practitioner in Sexual Health in the Guide Clinic in St. James's Hospital. Hello Jo and welcome. I guess to kick ourselves off, just to make everything comfortable, just tell us about yourself and what maybe you do on a daily basis so we know, and remember that these are pharmacists that would like to know what goes on in the Guide Clinic, because we know what the Guide Clinic is, but we don't necessarily know what goes on in the Guide Clinic.
Okay, well, thank you, Dennis, for having me on the podcast today. So, as you said, my name is Jo. I'm a candidate Advanced Nurse Practitioner in Sexual Health. So, I work with a very big team in the Guide Clinic in St. James's. So, we're the biggest outpatient department free service for people who have sexually transmitted infections or concerns with regards, so hepatitis, or people who are living with HIV or other infectious diseases. We see so far this year, we've had about 41,000 attendances to our service. All of our services are free, completely non-judgmental. We're extremely busy. So we look after lots of different people on a daily basis. So my service, my colleagues and I, we look after more the people who have concerns about their sexual health and their sexual well-being. So for me, I take part in the clinics with doctors, with other nurses, with health advisors. We've got a very big team of social workers as well. And I see people, so we see people for assessment, we diagnose people with STIs, we treat them, and then we also look after them from a point of view outside of just the infection they might be there for. So we do a lot of sexual health promotion, we do a lot of harm reduction as well with them, and then we signpost them to services that they might need. So social work, like I mentioned, we also do vaccinations here in the service, and if, say, for example, chemsex might be an issue, we can refer out as well. So we look after a lot of people and we do a lot for them while they come to us.
Okay. So, Jo, I guess that opens up my first question. You mentioned you look after a lot of STIs. From your practice perspective, what are the most common STIs that you're seeing at the moment? And have you noticed any trends or any trends analysis that you've seen from your own perspective in practice?
Yeah, so I suppose the most common STIs that we see are always going to be chlamydia is the number one most common bacterial STI that we see, and HPV, so human papillomavirus, which would be genital warts, was the most common viral STI that we see. But comparing 2023, so last year with 2022, we've seen a massive rise in gonorrhea, especially in populations where we weren't seeing it before. So for example, in young females, 15 to 24 age group, there was an 152% rise in gonorrhea in that cohort, which is absolutely unprecedented.
Astronomical.
So so we're seeing a lot more gonorrhea across the board, and chlamydia, as I mentioned. HPV is very common, and syphilis is, everything's on the rise. So I think in 2023, all STI notifications were up about 30%. So we're just very busy.
You mentioned something interesting there, and it's just to explain to the audience. You mentioned the word chemsex. So I appreciate that's quite a niche market. I might know about it because of my background in addiction, but you might just give a little explainer for people so they know what, when you talk about chemsex, what you mean by that.
Well, chemsex is kind of a term used for people who would use certain types of drugs, but it's really while having sex or for sexual activity, shall we say. So a lot of people would use drugs recreationally, but for the purpose of the term chemsex, it would be drugs that are used for the purposes of having sex. So predominantly seen in our gay, bisexual, or men who have sex with men population, but not just that, but majority, yes. These drugs can include GHB or crystal meth or other drugs also, but those two predominantly. The thing about these drugs is that they can make sex very pleasurable, feelings of euphoria, and they prolong sexual activity. So while that can be fine for people, the problem with it is prolonged sex can lead to problems with injuries that can come with that, and therefore the risk of acquiring infection is much higher.
And Jo, would you say there's also like a disinhibition zone with these, so they become more risky in their behaviours?
Yeah, absolutely. So it's about certain situations people can find themselves in. And I'm just going from feedback from my own patients here, is that maybe people aren't using condoms when they would without using chems. And that can be definitely, a lot of times condoms aren't being used at all. So that would be definitely something we see.
Okay, thanks, Jo, for explaining that. It's just that it's a term that mightn't be known out there. So from your own perspective, just with regards what you're seeing, is there any emerging or particularly resistant STI that is being seen, or is it like it's just the entire plethora that you described earlier?
No, I suppose we're lucky at the moment, touch wood, that a lot of our STIs are very treatable, and something I want people to know, that they should go out and get tested, because it's much, much worse not knowing or having an infection that can lead to negative problems down the road. That's actually very easy to treat. And most of these things are very easy to treat with antibiotics. But there are a few ones that we are watching. So gonorrhea is one that everyone knows, that there is resistance out there to gonorrhea. Thankfully, we don't have that problem too much in Ireland. But with culture and kind of watching antimicrobial resistance, we're on top of it. There is an infection called Mycoplasma genitalium that is emerging in Ireland that we're definitely watching as well. That all positive results we are sending to the UK for resistance profiling as well. So MGen will be one. It's becoming tricky to treat, but we are able to still treat it. Just to say, it's important to have a test of cure if you have a positive gonorrhea test or a positive mycoplasma test.
And Jo, just talking about testing, just because you brought it up, it's on my mind. So you know how in some you can get your own point of care test kit, like in pharmacies. Would you say that, are they valuable for a patient to take, or would you say that they're not stringent enough in order to make, obviously a point of care, you'd always refer people onwards to get a definitive test, a confirmatory test. But would you say that it's a good screening tool, or would you say they're better off just being referred, if there's any risk at all, directly into a guide clinic?
I think point of care tests are great for some people. I think that if you've got no symptoms at all, so say in a pharmacy setting, I think why not? I think any access to testing, if you've never going to test, or if you're worried about going into a formal setting and it's the one reason you might test, why not? I think they're great. I always think though, if sometimes point of care tests might only test for one thing, you might be missing an opportunity there to test for lots of other infections. So I think point of care tests are great. I think if a pharmacist or pharmacy is offering them, just to be aware that there's other infections as well. Make sure that the point of care test that you're offering is one that is of good quality. And especially if you're offering testing for HIV or Hep C or anything or syphilis, even in a point of care test, a blood test, that you know what to do if that test is reactive. I think that's very important to have robust referrals, that if that is a reactive test, you're going to support that person. And it's like you have somewhere to send them.
Yeah, so I guess like if you have the test on site, that you just can't have it as standalone. You have to offer a wraparound service to ensure that patients know where they need to go to next.
Yeah, exactly. But I do think, with the rollout of SH24, which is at-home testing free service, which was implemented in 2021 as a pilot program, they have had unprecedented demand for that service. That was with the Sexual Health and Crisis Pregnancy Program through the HSE. They now probably put out, I think it's about 10,000 free home testing kits every month. So that's the other reason why we're seeing such an increase in our, I suppose, our STI numbers, is because if you're testing for it, you will find it. So these at-home tests are very, very specific, and they're sensitive, and they're finding infections out there. And most of the people doing these tests are never testers, so they would never have tested before. So it's great.
I guess that brings on to people accessing these tests to do at home, probably from a stigma perspective, that it kind of eases them into if they have to be referred onwards, if you know what I mean, rather than them going directly like and waiting in the guide clinic, because I'm sure that there's people that are there that, for them it's like they see it as a very important part of their sexual health, whereas maybe the Irish psyche, and I don't mean to call it out, is like that we tend to kind of hide that kind of part of our health. Would that be a fair comment?
I think it's changed and it's changing, but sadly it is still there. And I think some people are fantastic, and a lot of our patients are very open and very happy to come and see us. And we do really try and create a very open and very welcoming environment in Guide. And especially, most people who come and after the consultation, they go, gosh, that was grand. You're all very nice here. So I think there's a lot of fear about coming and sitting in the SGI clinic. But I always remind patients, we look after people with cancers. We don't just look after people with STIs. We look after people with quite complex genital skin conditions. We look after people who have chronic disease. It's not just STIs. And I kind of think they go, all right, okay, maybe I will go up and see them.
That's interesting, Jo. I'd be honest with you. I was assumed, rightly or wrongly, that the Guide clinic was STI only, or, HIV, hepatitis C. I didn't think it, and obviously it does when you talk about HPV.
Yeah, no, and we do. And sure, obviously we have a very big infectious diseases clinic here as well, who we look after everything from like osteomyelitis to long COVID, so it's a whole plethora of things. But also, as you mentioned there with SH24, we are seeing people who would never have come into us. And we're seeing people who maybe present as married or to a female partner, but they may have male partners or they may have trans partners. And that's their one way of testing. And it's the only time they may have been able to pick up that they have an infection. It's their one way of keeping themselves and therefore their partners safe. So it's really been a game changer in people being able to access STI screening. So it's been great.
In community pharmacy, obviously we do EHC, emergency hormonal contraceptive discussions with patients. So that's an ideal opportunity, I guess, from a pharmacist's perspective, to remind patients about getting tested for STIs. Is there any kind of tricks, tips that you could give to a pharmacist when they're in talking to a woman around going for testing or accessing testing?
I suppose so. One of the clinics that I'm involved in here with the team here in Guide is the Young Persons Clinic on a Thursday morning. And I know it's not just young people that access emergency contraception, especially not anymore. We're actually seeing it's more older women or older trans males who might be accessing emergency contraception. But be sound is the first thing I would say, because it's not easy to go in and ask for emergency contraception, first of all, and that's feedback from my patients probably. The other thing I would say is, you've come in for this today. Can I just ask, have you ever considered, or do you think you might need an STI screen? Is that something you ever had? And the one thing I would say in that instance is, obviously, emergency contraception is time sensitive. So 72 hours for usually 11L, if that's what you're going to give out, or up to 5 days for Bristol acetate. There's a thing called window periods when it comes to sexual health, and some people test a bit too early. So if they're concerned about their latest condomless sex, then I would kind of say, look, it's a bit too early for you to screen for STIs if you are concerned, but you could do a test for chlamydia or gonorrhea in 2 weeks. And then you'd be advising people to do a full screen then after a month or 3 months, depending on their risk. So that's one thing, yeah.
From your perspective, Jo, an asymptomatic patient is obviously somebody that's is kind of an inherent carrier that may not know they demonstrate no symptoms. Is there any particular cohorts within that group that, is there a cohort there that needs to be tested more regularly because of sexual activity, or is it, I don't know really, where it's more like, how do you determine who's asymptomatic patient? Is it more around their behaviours and sexual conduct that you would kind of determine that?
Yeah, so I mean, the guidelines would say to you that when to test for an STI is when you're asymptomatic. Okay, so if you have multiple partners, which always makes me laugh because the guidelines say that multiple partners is more than 2 in 6 months. So that's actually quite low when you think for maybe a single person or not single person, whatever your perspective may be. But so I suppose that's quite few really. Every 6 months, fine. Depending on your sexual activity, how many partners you have, also the type of sex you have is something that people say. But really, I kind of say to people generally, depending on how many sexual partners you have or how often you change partners, kind of every 3 to 6 months or at least yearly. I kind of say it's like going for a checkup at the dentist, at least yearly, and then every 3 to 6 months.
Okay.
Because there is a thing of testing too early, because again, you're going to be in that window period, you might be missing infections.
That's actually quite interesting. I will admit I wasn't aware of that for someone who worked in the time when they were set up first, the drugs aid services, that I wasn't aware of about these windows, but that's a really interesting tip and point. From your perspective, under treatment protocols, as a pharmacist, where's the best place for me to find out about, what's the drug regime for example, chlamydia, gonorrhea, genital herpes?
Yeah, so the best place to go to, kind of an easy resource, would be the HSE.ie, the antibiotic prescribing guidelines. They should be very much up to date on all kind of GUM, STI guidelines. That would be the first place I would say people to go. Sexualwellbeing.ie is a very good resource as well. But that one from the HSE should be the most up to date. Okay.
You mentioned there about that be informed around antibiotic resistance. From the perspective of a pharmacist, and I know I'm asking you working on the other side, how could a pharmacist get involved with how important their role is in resistance prevention?
I suppose the real thing would be, like myself, I'm a nurse prescriber, so part of my role, obviously, when I'm prescribing medication is to counsel patients on potential side effects or how to take the medication correctly. So like yourselves and as pharmacists, you do the same thing. I can hear my colleagues and our pharmacists who are fantastic here in Guide, explaining people how or the potential side effects will help with concordance and help people to take their medication properly, and knowing what to expect and say, oh God, they told me that might happen, will help people to take and maybe finish their course rather than stopping it. So I think really educating people about what might happen with the medication will help them to finish their course and therefore not stop halfway. And the old adage of make sure you finish your course isn't exactly true, they say, but I mean, it's still important to do so, especially for certain STIs, for sure. So I think patient education is a key.
What factors do you determine for treatment choice with regards choosing an antibiotic or antiviral treatment?
Well, we have very clear guidelines. So our guidelines would come from the BASH guidelines, so the British guidelines. So they're very clear and they're all evidence-based best practice guidelines. Obviously, then if patients are pregnant would be a big thing in sexual health, and any allergy status that would guide it. Also, we have to, we do have some very vulnerable groups that we look after. So anyone with kind of substance issues, especially for metronidazole, which we would use quite a lot for the treatment of, say, trichomonas or even bacterial vaginosis, you're not going to give someone who has an alcohol dependency flagyl. They're not going to be able to take it. So you look for an alternative there. So just, your patient, everything is case by case in that instance.
Okay. And I guess the other question then is it that you see multiple STIs at a time in an individual, or is it normally down to like they have gonorrhea and that's it, or is often you see a multiplicity, and therefore does that complicate the drug regime for them?
Not really. I suppose you can have concomitant infections in some patients. I actually had a gentleman last week, he had 5 infections, but that was quite rare. Not all bacterial STIs. He had 2 parasitic infections on top of 3 bacterial STIs. In that instance, you don't, like with anything, you don't overload someone with a lot of pill burden that maybe, again, they mightn't be adherent with their treatment plan. So with that, we've got a great team here. So you can talk to your consultants, you can talk to your medical colleagues and say, what's the best way to approach this? But for the most part, actually, you would treat them possibly individually and see.
And this is a terrible question to ask, Jo. Which one, like let's say you had a multiplicity of them, which one in your head that you would treat immediately first and then the others can wait? Let's say if you had a patient who you knew was going to be non-adherent or difficult to manage, with a burden load, is there any one that you immediately treat first in order to get it out of the way to start treating the others? Or is it just we try and treat everything?
I would try and treat everything. I suppose when it comes to anything, it's about what's causing the patient the most distress, or what's causing the patient, what could cause the most negative consequences for the patient. These are all completely treatable infections. And it's a different story if the patient was living with HIV and it was a new diagnosis. That's a different story, obviously. And obviously, if it was something like a primary herpes simplex virus occurrence, that's a different story. Anything that's causing the patient distress is your focus, really.
Okay, perfect. And the other question I would have is there anything that pharmacists could do better through counselling or follow up with their medication regimes when they come out to, let's say, collect the script in a community pharmacy? Is there anything that you would see that could be that pharmacists could better support so that patients finish their course, go back for their next appointment, anything like that you would see as kind of tips and tricks for pharmacists to intervene at that point?
I actually had to think about this, and there's not really, I suppose I'm in quite of a unique situation here because a lot of our medications are dispensed in our own pharmacy here by our fabulous team of pharmacists downstairs. But I did ask about some of my colleagues if they had anything that I could, or what I think, would be beneficial for your audience, and they did say about our PrEP patients. So we have a very big cohort of PrEP patients here in Guide, and one of the things that some of the patients would struggle with is when they are getting their PrEP prescriptions filled, that sometimes the pharmacists in the community, they can't see their approval for their PrEP prescription, and that might be down to the fact that the patient, it's not visible to the pharmacist in the community. So the PrEP provider has registered the patient with PCRS, but the pharmacist in the community can't see that yet. So we do encourage them to get their drug payment scheme card done before they access it and all that. But our PrEP team just said to me that they just need to call like a pharmacy function number, which will mean a lot more to the pharmacist than to me. And it's option 7. So I think, and that's just better for
Jo.
That's just better for the patients, and I think it makes life easier for the poor pharmacists as well. But that's the only thing.
It's always a challenge when you're trying to ensure determine eligibility, as it's
of course,
as we call it. Yeah. And from your perspective, the pharmacist's role in patient education, and how the other thing that I mentioned earlier around patient stigma and sensitivity. Somebody coming into the pharmacy just saying with a PrEP script.
Yeah.
What is it that you would see is kind of things pharmacists could do with regards, first of all, some education, counselling on prevention, and then the whole piece around sensitive conversations, and if about partner notification, or do we step away from that?
Well, I suppose, like anywhere, having a space that you can have a private conversation is very important. It's difficult now with real estate, with everything, even having room in your pharmacies to have that conversation is difficult. Everyone's busy, everyone's out the door. But if someone comes in, and again, it comes down to tone. Hello, how are you? Yes, I'll have a look at that script. I do have patients who've had not very nice experiences in pharmacists, but not just pharmacists, at their GPs. No one's perfect, and it's unfortunately not that uncommon. But like you say, it's about creating a safe space, creating, if you feel that someone would like, do you want to have a word in private? It's very easy to do that. There are, if someone's interested, there are resources on HSE land, all these kind of things that you can go and do some further training in. What would be, sorry, I've forgotten the name of it.
But it's on HSE land. No, you're grand. Yeah. It's on HSE land, and pharmacists, community pharmacists can access HSE land, no problem. You can do a search engine on...
I just can't remember what it's called. And there's also a great initiative I was at a trans care conference in Cork not so long ago, and there's a great pharmacist called Nicola Cantwell, and she has an initiative about Rainbow Ready Pharmacy, and it's just about creating much more kind of accessible spaces in pharmacists for kind of people who are members of the LGBT community or trans, or who are gender diverse as well. So,
and Jo, we had Nicola on a podcast previously, where we talked about trans health and what a pharmacist do with helping trans health, and the whole thing. I think from the perspective of someone who a person who was trans, and Nicola's perspective was, I guess, a non-judgmental and open approach.
Exactly. And that's what I meant by that. Just like non-judgmental, listen to people. And I suppose, I'm sure Nicola would have spoken about how important it might be to have a little rainbow flag in the corner somewhere. And while that's really important, and I agree, I always kind of take from another talk I was at before, it's like, don't let it be tokenistic. If you're going to have a rainbow flag there, be open and be accepting, and be welcoming to people of all walks of life, I suppose, is one thing.
What would you say about somebody coming in asking about, let's say they're coming in to buy an STI test? Would you advise them that they should also encourage their partner to be tested, or what would be the best way to approach a conversation like that from your perspective? Because obviously you've people coming in, and you said they come in with partners, but I'm sure sometimes people come in on their own without their partners knowing that they're there.
Yeah, so partner notification can be tricky in the second instance you mentioned. Part of our role, and a massive part of our role, is partner notification. So we have a fantastic team of health advisors here who take on that role, really. But breaking the chain of infection, there's no point in me treating you, Dennis, if you've got chlamydia, if I don't treat your partners. So, because you'll just get the infection back, or there'll be onward transmission. So if someone come into me and the pharmacist's like, oh, I see you're buying an STI screen today, can I ask if you have a regular partner? Like, that might be over your remit, but you can just say, oh, we would just advise, if you have any partners, if you're concerned about STIs, that maybe you might want to get them tested too. Or,
okay.
Something as simple as that, because that is the key. Obviously, if someone comes into you and asks you questions starts asking the pharmacists themselves questions about STIs and STI screening, you can always just have your local STI services, have a list of where you can signpost people to is very important. Or even having a list of like SH24, sexualwellbeing.ie will have all those lists for you.
Okay, that was my next question. Where will I find that if I was looking for that show tomorrow morning? So yes, you've just told me. And in your own perspective and in your own practice, you obviously have come across challenges in the management of STIs. What would you say are your most common challenges, and maybe your more unusual challenges that you've come across in your practice? Because obviously I'm sure you have case study behind case study that would demonstrate very clearly, those challenges. First, we've already discussed the stigma piece, like getting, as you said, when people come in the door, you tell them it's not just an STI clinic, for example. But then how do you manage, let's say, the person who comes and they have to come back, let's say, after a week and they don't show up? How do you manage that kind of resist or non-adherent person that needs to come in because they had to come back because maybe you were reviewing their antibiotic therapy and needed to ensure that maybe they needed a top up or a different antibiotic to be added at the end, and you just wanted to come back just to review where they're at?
We do have people who we see and never see again. Unfortunately, people are autonomous beings. They have the right to self-determine, but tricky situations do arise when, say, someone we've diagnosed with an infection and we can't maybe get them back, but we do make every effort to contact them. We have very strict kind of follow-up procedures that we do follow in order to make every effort to get them to come back. So there's lots of things that we follow in order to get them back and get them treated.
Okay. And from your own perspective, we mentioned antibiotic resistance earlier. You are not seeing such a significant impact of antibiotic resistance in STI treatment in Ireland at the moment, are we?
We aren't seeing it. I'm not seeing it here at the moment, but it's something that's very much daily something that we're on our radar and looking for. So it's very much something that we're doing cultures for, say, if someone has gonorrhea, we're culturing every site to make sure that it's being monitored. So it's something that's very much everyone is very aware of. We'd never be treating a gonorrhea without culturing that patient and making sure that that's being monitored.
Okay, so you culture and then prescribe appropriately to that culture.
Yeah.
Okay, and so that would be very important then. Let's say if I'm selling a point of care test for gonorrhea, I'm not even sure if they're available, if I'm honest, Joe, that if I'm selling this test, that if it comes up positive, I should be sending them in to immediately get a culture and sensitivity done.
Yeah, exactly. So anyone who has gonorrhea should be having a culture before that treatment is done. And not everyone has access to cultures, in GP surgeries. I'm aware of that. Absolutely not, which is why most people would be referred into a centre where they would be able to do a culture. Because it would be best practice, and again, just so we can get those results for it. Yeah.
Okay. And from your perspective, because just are you seeing any future trends and innovations with STI prevention tools and technologies? Are you seeing any kind of newer kind of ways of determining tests? I don't know, Joe, it's kind of a very broad. Is there anything on the horizon that may impact and positively impact STI infections?
Absolutely, yeah. So, I mean, the thing about it is for prevention for HIV, well, TASP is a big thing. So that's treatment as prevention. It's not new, obviously, but that's just making sure people are taking their antiretroviral therapy as prescribed, and that's to achieve an undetectable viral load. That's what we will always be pushing for that. When it comes to prevention of STIs in the future, so DoxyPEP will be coming and is coming to Ireland, and that will be taking doxycycline as post-exposure prophylaxis after kind of any oral sex, vaginal sex, or anal sex. And you would take that within kind of 72 hours of any exposure. That's been shown to reduce chlamydia and syphilis. There was about 3 randomized controlled trials done amongst gay, bisexual, or men who have sex with men, and trans women. And that's currently being looked at the moment.
Is that just doxycycline at a high dose, or is it doxycycline in combination with other products? Just doxy on its own?
At the moment, it's just doxycycline, so it would be 200 milligrams within the first 72 hours.
Oh, wow. Okay.
Yeah, so that's to come. Yeah. The other thing, I suppose, would be HIV PrEP. So PrEP was pre-exposure prophylaxis and increasing the access to PrEP. So PrEP is used by many, many people around the country. But the latest trial that happened with long-acting injectable PrEP was the Purpose 1 trial, and that was very amazing results came out of that. That was in cisgendered women only. So the next trial for that will be with cisgendered men and trans and gender diverse people as well. So that's really exciting to see about HIV prevention for those groups. Vaccines as well is something, the vaccine potentially for herpes simplex virus, which gets an awful lot of stigma around that. The meningitis B vaccine is shown to potentially cover for gonorrheal disease. So there's some cross protection seen there for gonorrhea. So that could have huge implications as well for certain people that we look after as well. So there's some big things out there that can really help and change. But the main things don't change when it comes to STIs, and that is barrier methods for prevention. So condoms or internal condoms are really popular. I did a talk recently. I brought some internal condoms. So traditional condoms are for penises, but internal condoms are for vaginas or neo-vaginas if you have one. And they flew out. I couldn't keep them. My stack was gone.
Yeah, we sell them before called Femidom. So
Femidoms, yeah, exactly. Yeah, so they're coming back with a bang.
Oh wow. Okay.
Yeah, so there's a want for them. So I think if people maybe started stocking them, but I think all of these things are really exciting. But again, we can't forget about the importance of barrier methods. PEP is really important. So I suppose for pharmacists, a lot of people go to pharmacies looking for PEP or thinking they can get PEP at a pharmacy, and they can't. So PEP is post-exposure prophylaxis for HIV. So say if someone thinks they may have been exposed to HIV in the last 72 hours, they can access post-exposure prophylaxis, which would reduce their risk of acquiring HIV. So it's just knowing where to go, and that would be...
Again, Jo, is that on that website that you'd refer them to, like a guide clinic or a gum clinic? I mean, like to tell them where to go, sorry.
Absolutely, yeah. So any emergency department.
Oh, right, okay.
So any emergency department, yep, or any... there will be a list on that on sexualwellbeing.ie. Yeah.
But any emergency department that's open...
Obviously,
24 hours, you can refer somebody or not advise somebody, signpost somebody to go there.
Absolutely, because it's time sensitive.
It's time sensitive. So 72 hours is the time sensitivity there.
Yeah, so as close as you can, but within 72 hours, yeah.
Close you can, but okay. That's fair. And from your perspective, is there anything that you see in STI, infectious diseases care and prevention that pharmacy may play a greater role? So I'm thinking here, HIV medication being supplied through a community pharmacy rather than having to go to a clinic. Maybe pharmacists being allowed give catch-up HPV doses to people. Could you see that as like advantageous for everything? Or do you still think that the way that we have it structured in this country is the way that, it works well? Why change it? Controversial, Jo. So.
Yeah, I know, controversial.
Yeah.
I'll be be careful. No, I'm joking. Look, I think that improving access to healthcare in innovative ways is important, and I think that any way that someone can access something that might improve their well-being is positive. But I say cautiously because I suppose there are very vulnerable people out there, and we want to be able to get them into services where we can look after them in a very holistic way. So instead of maybe them accessing a pharmacist for half something, and for certain people, but I think that a HPV catch-up would be fantastic because that was stopped last year. I think that there was a recommendation that came after the review of the National Sexual Health Strategy in 2023 that said that pharmacies would be a great place to do a click and collect service with the SH24. So for people who maybe live with their ma or their dad, or where they can't get a kit to go to their house, they could nominate a local pharmacy where they could go and collect their test kit. I think that would be fantastic. So that's a way where community pharmacists could link in and be another area that would improve access. I think there's definitely a role for interdisciplinary collaboration, and I think that would work well.
That's my next question, Jo. Interdisciplinary, and the fact that I know that within your department, obviously within the guide, like I know the guide, you have an amazing multidisciplinary team.
We do.
You know, that there's a huge amount of interaction. So I'm out in the community. So I'm in a community pharmacy.
Yeah.
So essentially you're standalone as a clinician. From your perspective, what is there anything that pharmacists out in the community could see as being rolled into that kind of interdisciplinary network, or is that like way off? Like I know you mentioned there about the kits coming on a click and collect. I think that is one way of bringing people in. Do you see any other kind of pieces coming down the line from any of the reviews to suggest that utilisation of community pharmacy should be increased in this area, particularly when I'm thinking about, the minor ailments piece that's coming down the line for common conditions, should I call it, coming down the line for pharmacists, where they can start prescribing for certain common conditions. And I'm not suggesting that STIs are common conditions, but it's becoming more that pharmacists are being seen that they have a bigger role to play. Do you see any other further development in that area for pharmacists, particularly in the community?
I suppose, yes, I think in some regions it would be appropriate, because I do think that in certain regions, STI care especially is absolutely underserved, and that's for many different reasons. I think that in certain areas, I think it would be beneficial. But again, I think that it's very important that certain people need to know when they need to be sent somewhere appropriately. And I hope that there would be, if that was to happen, that there's proper support for pharmacists, that they're left not, as you say, the only clinician there when someone's unwell, or and I'm sure that would be very well looked after. I do think there's a role, but I think it would need really good support from everyone to execute it.
Okay, yeah. So like it would be like the development of an appropriate interdisciplinary team out in the community, which has been talked about within the strategies, launch of care, the whole plethora have discussed that.
Yeah.
From your perspective, and I'm trying to always bring it back to community pharmacy level, Jo.
Yeah.
Is there, from your perspective in your time, is there any kind of red flags and patient symptoms or behaviours that pharmacists in the community should kind of be looking out as indicators, maybe for a referral or a signposting to a guide service?
Yeah, absolutely. If you have someone coming into you, say, I have a few things. So one thing would be if you have a young person or not a young person coming in asking for emergency contraception in particular, we all read people's nonverbal cues. If someone looks particularly upset or quite maybe withdrawn, you can say, look, are you okay? We can often pick up on cues. There may be an element there that something happened that was non-consensual. There may be an element of assault. That's where you could say, do you want to have a little chat with me for a second? And there it goes back to creating that safe space, having that private room, and knowing then if there was something that person did disclose, where you could signpost that person to.
And Jo, we have in pharmacy currently at the moment, in conjunction with the Irish Pharmacy Union, we call it Safe Pharmacy, where people, if they have been victims of abuse, domestic violence, we give them a phone to call a number.
Brilliant,
so they can access that. We do have something like that in place, maybe not to the same extent as trying to determine like an assault or not, or as you said, consensual sex.
Yeah. And I mean, that's what I mean. It's no one's asking you to do that in the middle of the pharmacy, but, picking up on small things like that could be it's very subtle, but that's something that you could be aware of. Another thing would be anyone presenting who looks like they're in a lot of pain needs to be, especially if they're maybe asking for, I see this a lot with my patients who have primary HSV, so herpes simplex virus, especially my female patients. So if they're coming asking for canesten or thrush clotrimazole treatment, a lot of them think initially that it is a bad thrush infection, or anyone who tells you that they've got genital ulceration, they need to be seen properly. You should really be advising them. So if anyone says to you, look, I've got these blisters, they need to be seen by someone immediately because it's so painful. So that's one I would definitely say. And then if anyone asks for you for PEP as well, because that would be an emergency.
Okay, and again, what you said earlier was PEP. You can refer them to an A&E or to a service.
Yeah, so your local STI service, and if that STI service maybe doesn't have someone who can prescribe it, they will send them to the most appropriate place. Any emergency department will also give them PEP.
Okay. And Jo, I know you mentioned throughout our talk about kind of resources. Just to verbalise them again, from your perspective, I want to find out about the most up-to-date treatment guidance. It's looking up the AMRIC guidelines, I presume, and also then looking up the HSE guidelines on STIs. You also mentioned the BASH, or was that for something else?
No, so the BASH guidelines would be as well where we would draw down our guidelines from. So that's BASHH guidelines. And for resources then for sexual health resources, or if you wanted to signpost a patient to patient information leaflets, or even if you wanted to get some for your own clinic, it would be sexualwellbeing.ie would be very useful. As well for information on PEP and PrEP.
Okay. And is there any helplines that we can refer people to, or the websites are fine? Is there anyone that if they need to talk to someone, is there any, like, you pick up a phone, or is it more just direct signposting to an STI service? Or, for example, with the addiction services, there's the drugs and alcohol helpline, but I'm not aware of a helpline that I could pick up for, or a customer could pick up to ask about, where do I go, rather than checking online.
I know that they have My Option study for crisis pregnancy. There is a helpline. I just wouldn't have that number on me, but I can get it. Otherwise, I don't know about a phone number.
That's okay. And from your perspective as the kind of like the final takeaway for a pharmacist out in the community, what would you say would be the best thing that they could do in order to be part of the prevention program, be part of the treatment program for STIs? What would you say is the first kind of steps that you would say to do first?
Create an environment in your pharmacy that has condoms on show, has posters out there, creates a space that looks sex positive, that the condoms aren't under the counter, covered in dust, that people aren't afraid to ask for them, I suppose. Have it visible, make it really like, we're here, we're ready to talk about sex, and it's all okay. And when people do have questions, just as you were saying, just be open, be non-judgmental, and people will come back and they'll say, oh, they're really sound in there. I'll go in there and I'll be able to talk to them. That's really important. Yeah. And when they come for their medications or whatever, it's just giving them that good education and knowing where to send them.
Okay, so just make sure that we do that intervention around any medication being supplied to them.
Yes, exactly, yeah.
Okay, perfect. Okay, so Jo, I'd like to thank you for your time today. So Jo Bergin, Candidate Advanced Nurse Practitioner, Sexual Health in the Guide Clinic, St. James's Hospital, thanks for speaking to us today. Thank you.
Thanks a million, Dennis. Thank you.